Bismillahirrahmanirrahim. On to the next session. Now we are going to start with the multifocal tachycardia, multifocal atrial tachycardia. The multifocal atrial tachycardia, the name indicates there are multiple foci, and those multiple foci are creating the impulses other than SA node, and that is creating the tachycardia. Etiology: it is exacerbation of pulmonary disease like COPD, electrolyte disturbance like hypokalemia, and catecholamine surge, for example, in sepsis. The clinical findings typically they are asymptomatic, but they are rapid and irregular pulse. ECG will show more than 3 P waves from 3 P waveforms and atrial rate of more than 100 per minute. Treatment is correct the underlying disturbance and AV nodal blockade, for example, by the verapamil if it is persistent. So here you can see that there are different, more than 3 different types of P waves. This is one P wave. If I could zoom it in, so you can see that this P wave looks different than this P wave, which is looking different than this P wave. So there are multiple morphologies of P waves which are present, and there is irregular RR interval that is seen in the multifocal atrial tachycardia. Multifocal atrial tachycardia does not create an increased risk of atrial thrombus formation like atrial fibrillation, hence they do not require anticoagulation. Then we have atrial fibrillation, I guess, yeah, atrial fibrillation. So here you can see that you cannot identify a single P wave. There are fibrillatory waves for sure, but not a distinct P wave. And there is irregular rhythm. You're talking about atrial fibrillation, yes. So they may be caused by ectopic foci, which are most commonly found in the pulmonary veins. The pulmonary veins, suppose this is the heart, um, right heart, left heart. So the pulmonary veins are entering over here into the left atrium. So near the ostia, we can the most important site for the development of ectopic foci, which can precipitate the atrial fibrillation, is the ostia of the pulmonary veins. The presentation is palpitations, weakness, dizziness, presyncope, dyspnea, and chest pain. It may lead to rapid ventricular response with ventricular rates as high as 150 per minute. ECG findings will show irregular rhythm, varying RR interval, no clearly discernible P waves, and narrow complex tachycardia. In atrial fibrillation, we won't find any distinct P waves, irregular RR interval, up and down. Uh, what? Up and down. What was that? It is just irregular. I don't know the meaning of up and down and up and down. Okay, narrow QRS complex typically seen in atrial rate usually more than 350 beats per minute. I think from 150 to 250 it is atrial tachycardia, from 250 to 350 it is atrial flutter, and more than 350 is atrial fibrillation. In atrial flutter, we can find sawtooth waves. We saw that in a previous session. Atrial rate is 2 times than the ventricular rate, so it is 2 to 1. In atrial flutter, the atrial rate will be 2 to 1, like there will be 2 P waves for 1 QRS complex, so something like that. So here you can see that there is indistinct atrial activity in these waves. The atrial activity is not clear, like in these waves. The T waves can be seen in lead V2. That's a good thing. The QRS complexes are narrower and irregular rhythm is present. Then we have the next topic, which is the management involves assessing for rate versus rhythm control strategy and preventing the systemic embolization in unstable patient. Synchronized cardioversion, that is attempt synchronized cardioversion can be given. Attempting cardioversion in the patient with atrial fibrillation for an unknown duration or more than 48 hours without adequate anticoagulation increases the risk of systemic thromboembolism. Yes, because the people with atrial fibrillation have a chance of developing thrombi. So if we cardiovert them, so maybe a thrombus that has been formed in the heart can dislodge and go to the systemic circulation. In stable patients, medical therapy to control the ventricular rate, that is rate control strategy, we can give beta blockers, diltiazem and digoxin. Rhythm control strategy is considered in the patients with the following conditions: the people who are unable to achieve adequate heart rate control, recurrent symptomatic episodes, and heart failure symptoms. All the patients with new onset atrial fibrillation should be evaluated for occult hyperthyroidism. Common causes of atrial fibrillation are hyperthyroidism or new onset thyrotoxicosis, for example, post surgery. Comorbidities that encourage the atrial fibrillation, precipitants of atrial fibrillation and or conduction remodeling, systemic hypertension, mitral valve dysfunction, left ventricular failure, coronary artery disease, coronary artery disease related factors like diabetes mellitus and smoking, obesity and obstructive sleep apnea, chronic hypoxic lung disease like COPD, and atrial septal defect. Triggers of increased automaticity, hyperthyroidism, excessive alcohol use, increased sympathetic tone, acute illness, for example, sepsis, pulmonary embolism, and myocardial infarction, cardiac surgery, and sympathomimetic drugs, for example, cocaine. So, there is a star. What is a star? The systemic hypertension is the most common predisposing comorbidity for the atrial fibrillation. Then comes the conditions associated with the atrial fibrillation, the cardiac conditions. Hypertensive heart disease is most common. Then comes the coronary artery disease, rheumatic valvular heart disease like mitral stenosis and mitral regurgitation, congestive heart failure, hypertrophic cardiomyopathy, congenital heart disease like atrial septal defect, and post-cardiac surgery. Pulmonary conditions include obstructive sleep apnea, pulmonary embolism, chronic obstructive pulmonary disease, and acute hypoxia like, for example, pneumonia. Miscellaneous causes include obesity, endocrine causes like hyperthyroidism and diabetes, alcohol abuse, drugs like amphetamines, cocaine, and theophylline. Then we have CHAD-VASc score. So the CHAD-VASc score is with A2, S2, and VASc score. This is a modified version of CHAD score. Regardless of whether the rate control or rhythm control is used to treat atrial fibrillation, all the patients should undergo CHAD-VASc score for the assessment of estimate score assessment to estimate the thromboembolic risk. Okay, so this is a CHAD-VASc score. C is for the congestive heart failure, then hypertension, age more than 75. Patients are assigned to one of the two categories. Okay, age more than 75. Okay, then diabetes mellitus. S2 means stroke, TIA, thromboembolism, vascular disease, prior myocardial infarction, peripheral artery disease, and aortic plaque. Age 65 to 74. Then sex category, that is female. So basically it's not A2 S2. They're just trying to tell you that A and S has two scores, has a score of 2 while the rest of them has one score. So this is CHAD-VASc score. Okay, I don't think we can draw something on that. Yeah, but okay. So the C is for the congestive heart disease, H is for the hypertension, A is for the age more than 75, D means diabetes mellitus, S means stroke, TIA, thromboembolism, V means vascular disease, prior myocardial infarction, peripheral artery disease, or aortic plaque. So some vascular disease, age 65 to 74, and that is also respected, and sex like that is female. So these are the CHAD-VASc categories, and A2 and S2 are age more than 75 and stroke or TIA has a score of 2, and this criteria is used for diagnosis for assessing. Regardless whether rate control is used, all patients should undergo CHAD-VASc score assessment to estimate the thromboembolic risk. So CHAD-VASc score is a score that tells us about the risk of thromboembolism. Okay, so there is a total score of 9. Anticoagulation in the atrial fibrillation. If the CHAD-VASc score is 0, like the person came to you with thromboembolism, we calculated the CHAD-VASc, it came out to be 0. So stroke risk is low, so no anticoagulation therapy is required. If CHAD-VASc score is 1, so there is an intermediate risk of stroke, none or aspirin or anticoagulant can be given. Warfarin or target specific oral anticoagulants, yeah, as oral anticoagulants. And if it is more than 2, so there is the high stroke risk and we have to start oral anticoagulant. Valvular atrial fibrillation or mechanical prosthetic valve, if that is present, so in such situations warfarin is administered. Lone atrial fibrillation, this term is used for the patients with paroxysmal, persistent, or permanent atrial fibrillation with following features: no evidence of cardiopulmonary or structural heart disease, age less than 60, and CHAD-VASc score of 0. Risk of embolization in such patient is extremely low and no anticoagulant therapy is indicated. Then comes atrial flutter. The thing that you have to see is the sawtooth wave pattern, as you can see here. These are flutter waves, these ones, and there's a sawtooth like pattern as you can see in this picture, like here you can see them. So it is due to re-entrant circuit around the tricuspid annulus with slowing of the impulse through a region known as cardiotricuspid isthmus. So the nidus of the re-entrant, the nidus of the impulse generation is the tricuspid annulus, and there is a slowing of impulse through a region known as cardio-tricuspid isthmus. Findings will be a rapid rate and sawtooth flutter waves will be present. Then let's talk about ventricular arrhythmias. They include ventricular premature beats, non-sustained ventricular tachycardia, and sustained ventricular tachycardia, most common cause of out-of-hospital sudden cardiac arrest, and ventricular fibrillation. It is the most common underlying arrhythmia responsible for sudden cardiac arrest in the setting of acute MI. They are common in intermediate post-myocardial infarction period. More than 50% occur within the first hour of the symptoms. Re-entry is the predominant mechanism responsible for ventricular arrhythmias in the post-MI period. Peri-infarction ventricular arrhythmias. So, uh, I'm sorry, there was an interruption. So, I guess before that we were talking about ventricular arrhythmias. So, they include ventricular premature beats, non-sustained ventricular tachycardia. Sustained ventricular tachycardia, most common cause of hospital, out of hospital sudden cardiac arrest. Ventricular fibrillation is the most common underlying arrhythmia responsible for sudden cardiac arrest in the setting of acute MI. They are common in the immediate post-myocardial infarction period. More than 50% occur within first hour of symptom onset. Re-entry is the predominant mechanism responsible for the ventricular arrhythmias in the post-MI period. Peri-infarction ventricular arrhythmia, immediate or phase 1A ventricular arrhythmia. It occurs within 10 minutes of coronary occlusion, and acute coronary ischemia causes heterogeneity of conduction with the areas of marked conduction slowing and delayed activation that leads to increased predisposition to reentrant arrhythmia. Reentrant ventricular arrhythmia are the most common cause of sudden cardiac arrest in the immediate post-infarction period. Delayed or phase 1B arrhythmias, it occurs within 10 to 60 minutes after infarction, and they result from abnormal automaticity. What are the factors associated with the poor outcomes in out of hospital sudden cardiac arrest? So these are the factors which are associated with that. Time elapsed prior to effective resuscitation, that is delayed bystander CPR, delayed defibrillation, initial rhythm of pulseless electrical activity or asystole, prolonged CPR more than 5 minutes, absence of vital signs, advanced age, prior history of cardiac disease, more than 2 chronic illnesses, persistent coma after CPR, need of intubation or vasopressors, pneumonia or renal failure after CPR, sepsis, cerebrovascular accident or class 3 or 4 heart failure. Then comes the what is that? The premature ventricular beats. So this is irregular rhythm, and these the ones which are highlighted with the red arrow, these are premature ventricular contractions. So you can, like, this is a normal QRS complex and this one is wide distorted QRS complex. The features are the QRS duration more than 0.12 seconds, bizarre morphology not resembling any conduction abnormality, T wave in the opposite direction of the QRS axis, like uh, the QRS axis is pointed upwards and the T wave will be pointing downwards in the premature beats. And there will be a compensatory pause as well. You can see that there is a compensatory pause here, a compensatory pause here, another here. So these are the features, like a long QRS more than 0.12 seconds, bizarre morphology, not resembling any conduction abnormality. T wave will be in the opposite direction of the QRS axis and there will be a compensatory pause. Management, if it is asymptomatic, so you can do the reassurance. If the person is symptomatic, then beta blockers or calcium channel blockers are the first line. Beta blockers do not suppress premature ventricular beats, but they reduce their symptoms by reducing the post extrasystolic potentiation, that is, increasing the systolic contractility via premature ventricular contraction or other extrasystolic beats. Differential. Non-sustained ventricular tachycardia is a differential for that. It is characterized by more than 3 consecutive ventricular beats at a rate of more than 100 beats per minute and lasting less than 30 seconds. Atrial premature beats. So the atrial premature beats look something like this. This one, this one, this one. These are atrial premature beats. Premature atrial contraction. So the rate is 60 to 100. Rhythm is irregular. The P wave of the premature atrial contraction often has a different shape from the one originating in the SA node, and the QRS will be normal. So actually these arrows are When we are talking about atrial contraction, so the impulse that is originating in the atria is also causing the ventricles to contract. So basically, if we focus the P wave, so you can see here that this is an inverted P wave here, and inverted P wave here, and one here. So these are premature atrial contraction, which are also leading to ventricular contraction, which are indicated by the red arrows. So this is due to the depolarization of atria originating in a focus outside the SA node. ECG will show P waves with abnormal morphology. It often occurs earlier in the cardiac cycle than a normal P wave, and it will have an irregular rhythm. Management for the asymptomatic patient: avoidance of triggers like tobacco, alcohol, caffeine, and stress. For symptomatic patients, we have to give beta blockers. Then the next thing is pulseless electrical activity versus asystole. So these are two different conditions. In pulseless electrical activity, it is the presence of electrocardiographic rhythm in the absence of adequate cardiac mechanical contraction to generate a palpable pulse. While for the asystole, it is complete absence of electrical and mechanical cardiac activity. In pulseless electrical activity, the electrical activity will be present, but uh, adequate mechanical contraction will not be present in the heart to generate a palpable pulse. But in the case of asystole, it is the complete absence of electrical and mechanical cardiac activity. Reversible causes of asystole, pulseless electrical activity. These are 5H and 5Ts. So the causes of asystole and pulseless activity. The 5H include hypovolemia, hypoxia, hydrogen ions like acidosis, hypokalemia and hyperkalemia and hypothermia. The 5Ts include tension pneumothorax, tamponade, cardiac tamponade, toxins like narcotics and benzodiazepines, thrombosis including the pulmonary or coronary thrombosis and trauma. The ventricular fibrillation looks something like this, and this is asystole. In the ventricular fibrillation, I guess this is also pulseless electrical activity, and defibrillation is possible. And in asystole, the defibrillation is not possible. This is pulseless ventricular tachycardia, and this is pulseless electrical activity. This looks something like this. Then we have ventricular fibrillation. So ventricular fibrillation is irregular, chaotic rhythm. Coarse waveforms of varying shapes and amplitude will be seen. So you cannot identify any waveform, any wave in this waveform. Like no PQRS can be identified in this strip. It is most common cause of sudden cardiac death due to the acute myocardial infarction, and the treatment is immediate defibrillation. Automatic implantable cardioverter defibrillator placement indications. It is recommended for primary prevention of the sudden cardiac death due to ventricular arrhythmias. The criteria is that left ventricular ejection fraction should be less than 35% and prior MI and left ventricular ejection fraction less than 30%. It is not indicated in premature ventricular beats, non-sustained ventricular tachycardia. So for these two conditions, we are not supposed to do the implantable, we are not supposed to place an implantable cardioverter, but otherwise, if the person left ventricular ejection fraction is less than 35% and there is a prior MI and left ventricular ejection fraction of less than 30%, so we can use it. Then comes the mitral valve prolapse. It is the most common cause of chronic mitral regurgitation in the developed countries. Physical examination findings of chronic mitral regurgitation are displaced apical impulse, hollow systolic murmur at the apex, and third heart sound. The pathophysiology, it is due to the myxomatous degeneration of the mitral valves and coda tendini. The findings include mid-systolic click followed by a mid to late systolic murmur. As the leaflet dysfunction worsens, the murmur becomes hollow systolic and the click may not be audible. The complications are atrial fibrillation. Differentials are mitral annular calcifications. It refers to the degenerative process involving the fibrous annulus of the mitral valve. It is an incidental finding in the older adults, and it is associated with mild to moderate mitral regurgitation. Mitral valve prolapse syndrome. Several non-specific symptoms and non-specific ECG changes have been attributed to mitral valve prolapse. These signs and symptoms in patients with mitral valve prolapse is often called as mitral valve prolapse syndrome. Okay. Um, so several non-specific symptoms and non-specific ECG changes, like if all of them or most of them are present in a person with mitral valve prolapse, that thing is called as mitral valve prolapse syndrome. The presentation is atypical chest pain, dyspnea, palpitations, dizziness, anxiety, and panic disorder. The management is done with reassurance. Then the next thing is post-MI mitral regurgitation. It can be due to papillary muscle displacement, and papillary muscle rupture. So, you know, we have talked about the posterior middle papillary rupture, which is prone to rupture. So, in both these situations, they can be post-MI mitral regurgitation, like either displacement or rupture. The features include hollow systolic murmur and increased left ventricular and diastolic pressure. Heart valve defect summary. So, in mitral stenosis, the murmur is opening snap with a mid-diastolic rumble. So location is apex. With a leg raise because of increased preload, it will worsen. With the Valsalva decreases the preload, so that improves the murmur of mitral stenosis. The treatment is preload reduction. The pathogenesis is it is caused by the rheumatic fever. Presentation is uh, the mitral stenosis, because if the mitral valve is closed, so the atrium starts dilating, and that can lead to pathological rhythm formation like atrial fibrillation, congestive heart failure, and shortness of breath. And definitive treatment is to replace the valve. Then aortic stenosis, the murmur is crescendo decrescendo systolic murmur, and location is aortic to carotids. So it from aortic area it is referred to the carotids. Leg raises because of increased preload will worsen the condition. Valsalva because of decreasing preload will improve the murmur. Treatment is preload reduction. The pathogenesis is calcification of the aortic valve and the bicuspid aortic valve, and presentation is with angina, congestive heart failure, and syncope. The definitive treatment is to replace the valve. Then mitral regurgitation. So mitral regurgitation produces a hollow systolic murmur or pansystolic murmur. The location is apex to axilla. With leg raised because of increased preload, the murmur worsens, and Valsalva because of decrease in preload improves the murmur. The treatment is preload reduction. Pathogenesis is infection and infarction. So infection, which infection? The rheumatic fever basically. Then we have so chronic rheumatic fever causes mitral stenosis. Acute rheumatic fever can cause mitral regurgitation. The presentation is congestive heart failure, and definitive treatment is to replace the valve. For aortic regurgitation, the murmur is decrescendo diastolic murmur. Location is aortic area. Leg raise will worsen the condition, and Valsalva will improve the condition. For the same logic of leg raise increasing the preload and Valsalva decreasing it. The treatment is to preload reduction, and pathogenesis is infection and infarction. Presentation is congestive heart failure, and definitive treatment is to replace the valve. For hypertrophic obstructive cardiomyopathy, the murmur is very similar to that of aortic stenosis, but the maneuvers will differentiate these murmurs. So you can see that it is crescendo decrescendo pansystolic murmur. Location is apex. With the leg raise, this murmur improves because the leg raise increases the preload. That will increase the left ventricular volume, and that will alleviate the left ventricular outflow tract obstruction. And the reverse is true when we do the Valsalva because it decreases the preload. Treatment is to increase the preload, and the pathogenesis is it is congenital. The presentation is shortness of breath, sudden death, and definitive treatment is to replace the valve. Mitral valve prolapse, the murmur is there will be a mid systolic click, and if there is regurgitation, so the murmur will again be hollow systolic or pansystolic murmur. It is present at the apex. With the leg raised, this murmur improves, and with Valsalva, this worsens. So it has pretty much this, like it is because of increasing preload. When you increase the preload, so that increased preload will lead to dilation of the ventricular chamber, that will make the chorda tendineae tense, and the mitral valve will not be protruding into the ventricles, into the atrium. So by that logic it is doing it. So treatment is to increase the preload, and it is caused by it is a congenital pathology. Presentation is congestive heart failure, and definitive treatment is to replace the valve. Then these are the locations where we auscultate the heart. So murmur locations, this is the aortic area, specifically A1 area. So aortic systolic ejection murmur, aortic stenosis is heard here. It is pulmonic area. So the pulmonic area, systolic ejection murmur at this point are pulmonic stenosis and flow murmur and atrial septal defect. And systolic ejection click is pulmonic stenosis. This area is the A2 area. In this area, like in between the pulmonary and the tricuspid area, systolic ejection murmur is hypertrophic cardiomyopathy, and early diastolic murmur of aortic regurgitation and pulmonic regurgitation can also be auscultated here. In the tricuspid area, the hollow systolic murmur of tricuspid regurgitation and ventricular-septal defect can be auscultated, and mid to late diastolic murmur of tricuspid stenosis and atrial septal defect can be auscultated here. This is the mitral area. So the hollow systolic murmur is mitral regurgitation, and mid or late systolic click, mitral valve collapse. Mid or late diastolic murmur is mitral stenosis. ASD murmurs from increased flow across the pulmonic valve and tricuspid valve. Then this is norepinephrine induced vasospasm. Norepinephrine is a vasoconstrictor and that can cause vasospasm. The presentation will be cool, dusky fingers, ischemia and necrosis of the distal fingers and toes of fingers of all the extremities, mesenteric ischemia and renal failure. The differentials include Raynaud's phenomena. It progresses from pallor to cyanosis to erythema. For Raynaud phenomena, initially they will be pallor, then will come cyanosis and ultimately erythema. It is due to cold exposure or stress, and dusky fingers are not a feature of Raynaud phenomena. That is a feature of norepinephrine induced uh, vasospasm. Then we have differentials of chest pain. So I think we have talked about this before, but okay, let's do them again. So initially coronary artery disease, pulmonic or pleuritic, pleurisy, pneumonia, pericarditis, and pulmonary embolism. Then aortic causes including dissection, intramural hematoma, gastrointestinal esophageal causes in chest wall or musculoskeletal. Firstly, the coronary artery disease. This can be, the pain will be substernal, the radiation will be to the arm, shoulder, or jaw, precipitated by exertion and relieved by rest or nitroplicity. Pulmonary pleuritic chest pain, that is pleurisy, pneumonia, pericarditis, or pleural effusion. Sharp stabbing pain, worse with inspiration. Pericarditis, worse when lying flat. And pulmonary embolism and pneumothorax, it will cause respiratory distress and hypoxia. The aortic dissection and intramural hematoma will lead to sudden severe tearing pain that will radiate to the back, elderly men, and hypertension and risk factors for atherosclerosis. Gastrointestinal and esophageal, so non-exertional relieved by antacids, upper abdominal and substernal, associated with regurgitation, nausea, and dysphagia, and there will be nocturnal pain. Chest wall, musculoskeletal, persistent or prolonged pain, worse with movement or change in position, and often follows repetitive activity. Then we have the next thing, that is evaluation of chest pain in the emergency department. Firstly, we'll take a focus history and physical examination, assess the vital signs, and obtain the venous access. If the patient is unstable, stabilize hemodynamics and check for underlying causes. If the person is stable, so obtain the ECG and chest X-ray, administer aspirin if the risk for aortic dissection is low. If the risk is low, yes, so STEMI, treat with emergency catheterization or thrombolysis. And if it is NSTEMI, treat with appropriate anticoagulation. So if it is STEMI, so ST elevation, positive troponins, and no ST elevation, positive troponins. Yeah, so basically the classification hallmark is that the troponins will be elevated in STEMI, and along with that ST segment will be elevated, and in NSTEMI, the troponins will not be elevated in ST segment, the troponins will be elevated with no ST elevation. Then ECG consistent with the acute coronary syndrome. If it is not consistent with that, then see if the chest X-ray is diagnostic. If the chest X-ray is diagnostic, then treat the cause of chest pain. If chest X-ray is not diagnostic, then assess for pulmonary embolism. Check the cardiac markers and risk stratify for acute coronary syndrome. Assess for pericarditis and assess for aortic dissection as well. Then we have the next thing, that is evaluation of chest pain on the basis of pre-test probability. So we have done this. Yes, we have done this table before. So firstly, pre-test probability of coronary artery disease. If it is low, so no additional diagnostic testing is required. If it is high, then start pharmacological therapy for coronary artery disease and look for expert evaluation. If it is intermediate, then look if the person is able to exercise or not. If the person is able to exercise, then do the normal ECG. If the ECG is normal, do the exercise ECG test or exercise electrocardiography or myocardial perfusion imaging. If this is positive, do the coronary angiography. If ECG is not normal, again do the exercise imaging test. If this comes out to be positive, do the coronary angiography. If the person is not able to exercise, do the pharmacologic stress testing, for example with a dopamine echo. So if that comes out positive, do the coronary angiography. An exercise imaging stress test shows how well blood flows inside your heart and how well your heart pumps the blood, right? And here you can see that unstable or NSTEMI or STEMI, so we can treat with the Mona C bash. So the bash means something. Okay. So it is morphine, oxygen, nitrates, aspirin. C was for coronary angiography, I guess. B is for the beta blockers. A is for ACE inhibitors, and SH is also stands for something, I don't know. So MI, if it is MI, so do the percutaneous intervention with the drugs. ACS contains three conditions: STEMI, NSTEMI, and unstable angina. Immediate treatment is Mona C bash. Okay, please give a full form of Mona C bash as well. Okay, and here they are trying to tell us something which I don't think we would be able to read because it is so small. So yeah, so they're saying understanding your nuclear medicine stress test. Okay, let's zoom it in here more. So okay, it is very clear. I think we have reached the maximum limit of our zooming in capabilities. So this is short axis. They are saying it is normal and it is abnormal. Okay. Horizontal long axis, this thing is normal, this is abnormal. And vertical long axis, this is normal, this is abnormal. Okay. What good was that? I don't know. Now coming back to the pretest probability of the coronary artery disease, we have talked about that before, but let's revise it. So the pretest probability, it is less than 10% if the person is asymptomatic, people of all ages, and atypical chest pain in the women age less than 50. The pretest probability is intermediate, like 20 to 80% in atypical angina in men of all ages, atypical angina in women more than 50, and typical angina in women age 30 to 50. And the probability is high, more than 90%, typical angina in men aged more than 40, and typical angina in women aged more than 60. Takotsubo has stress-induced cardiac findings, but mostly seen in postmenopausal women, and can see ECG abnormalities and can go with echo. Coronary artery disease symptoms. Relative frequency of selected presenting symptoms in acute coronary syndrome. Chest pain is present in 80 to 85% of the cases. Dyspnea in 70 to 75% cases. Nausea 40 to 55. Vomiting 15 to 20%. And epigastric pain 10 to 15% of the cases. Then comes the vasospastic angina or the Prince metal angina, in which the problem is that the coronary artery undergoes spasmodic contractions and ST segment will be elevated on the ECG of Prince metal angina. Pathogenesis. Hyperactivity of the coronary smooth muscle. The clinical presentation is young patient age less than 50. Smoking, minimal other coronary artery disease risk factors. There will be recurrent chest discomfort, occurs at rest or during sleep. Spontaneous resolution in less than 15 minutes. Diagnosis. Ambulatory ECG will show ST segment elevation and coronary angiography will not show no coronary artery disease will be present. Treatment is calcium channel blocker is preventive and sublingual nitroglycerin will be abortive. Classification of angina, it is classified as 1, 2, 3. Classical angina, typical location, for example, substernal, quality and duration, provoked by exercise or emotional stress, and it is relieved by rest of nitroglycerin. Atypical 2 of 3 characteristics of classical angina, and the non-angina less than 2 of 3 characteristics of classic angina. Atypical coronary artery disease, it is seen in women, elderly, and diabetic patients. Stable angina workup. So for the stable angina, I hope that now they will tell us about what the Mona C base stands for. Okay, for the stable angina, firstly do the exercise ECG and then perform the coronary angiography. If the high risk findings are seen on exercise ECG, if there is high pretest probability of ischemic heart disease. We have seen this table. Okay, I'm not reading this again. So here they've shown you electrodes attached to the chest and electrodes connected to the machine. Patient working on the treadmill. This is blood pressure cuff. Nurse checks the blood pressure and echocardiogram recorded on a machine. Treatment of chronic stable angina. So for the chronic stable angina, these are the drugs which we administered. The first one is beta blockers. That is the first line therapy. It decreases the myocardial contractility and heart rate. Non-dihydropyridine calcium channel blockers, alternative to the beta blockers, they decrease the myocardial contractility and heart rate. Dihydropyridine calcium channel blockers are added to the beta blocker when needed. Coronary artery vasodilation and decrease the afterload by systemic vasodilation. Nitrates, long-acting added to persistent angina and decrease the preload by dilation of capacitance veins. Ranolazine, alternative therapy for the refractive angina and decrease the myocardial calcium influx. Then we have the next thing, that is medical therapy for the coronary artery disease. The medical therapy for the coronary artery disease, which improves morbidity and mortality in the patient with the coronary artery disease, as follows. So we can give dual antiplatelet therapy, then beta blockers, ACE inhibitors and angiotensin receptor blockers, statins, aldosterone antagonist. It is indicated in the patients with the ventricular ejection fraction of less than 40% who have heart failure or diabetes mellitus. Okay, then the next thing is, uh, just give me a second. Yeah, so the next thing is stress test. So these are different types of stress tests. Firstly, exercise ECG test. The mechanism is that it increases the heart rate and increases the blood pressure. It is best for the patients who are able to reach the THR. What is THR? Uh, it is some heart rate. THR is equal to 85% of 220 minus age. Okay, so it is not for the people with the left middle branch block, pacemaker, and patients unable to reach the THR. Okay, then pharmacological stress test with the adenosine or dipyrimidine. Non-selective adenosine agonist dilates the coronary artery without increasing the heart rate or blood pressure. This thing is best for left middle branch block, pacemaker, and patients who are unable to reach the THR. It is that you know required heart rate, or maybe the heart rate when you get tired, something. Reactive airway disease. This thing is not for the people with the reactive airway disease. Patients on the dipyramidol and theophylline. Dobutamine stress echocardiography. The mechanism is that it is a beta 1 agonist and it increases the heart rate with or without blood pressure. It is best for reactive airway disease in patients who are unable to reach the THR, and it is not for the people who have tachyarrhythmias. The basics: signs of active ischemia in the stress testing. Uh, so signs of active ischemia in the stress testing. It can be angina, ST changes in ECG, and decrease the blood pressure. What? What does that even mean? Signs of active ischemia in stress testing. So angina, ST changes on ECG, and decreased blood pressure. So these are the signs of active ischemia in stress testing. In stress testing, these are the signs. If they come, so we suspect that there is active ischemia like angina, ST changes on ECG, and decreased blood pressure. Then chest pain on esophageal region. The features: prolonged pain lasting more than 1 hour, postprandial symptoms, associated heartburn or dysphagia, relief of pain by anti-reflux therapy, and nocturnal pain. Differences include Prince metal angina. It lasts a few minutes, less than 15 minutes, rather than more than 1 hour. So ACS is basically constituting three things: STEMI and STEMI and unstable angina, and immediate treatment is Mona C bash. Okay, what does that mean? Now please tell me. Okay, let me see that. Okay, so Mona C bash stands for morphine, oxygen nitrates, aspirin, clopidogrel, beta blockers. I'm taking a screenshot in the mobile. You may search it is you can search it on the Google. Just write Mona C bash mnemonic. So Mona's M is for the morphine, then O is oxygen, N nitrates, A is aspirin, C is for clopidogrel, B is for the beta blockers, A is inhibitors, statins, and heparin. So these are the things which we give in ACS. Immediate restoration of the coronary blood flow with percutaneous intervention in fibrinolysis. Fibrinolysis is not done in the end-stage or unstable angina. The current guidance regarding the use of primary percutaneous intervention for any patient with acute STEMI are within 12 hours of symptom onset, and use percutaneous intervention in the patient with acute STEMI within 90 minutes for first medical contact in a PCI capable hospital. Use PCI in patient with acute STEMI within 120 minutes for a patient who require transport to a PCI capable hospital from another hospital, because he would have received first aid at the first contact, and secondly, we can extend the limit to some extent for the person who is willing to get it. So management of ST elevation, myocardial infarction. Firstly, oxygen for arterial saturation less than 90%. If there is it, so administer oxygen. Then give nitrates. Caution with hypotension, right ventricular infarction, or severe aortic stenosis. Antiplatelet therapy like aspirin, PV2, white cell receptor blockers, anticoagulation, unfractionated heparin, low molecular weight heparin, and bivalirudin. The beta blockers are contraindicated in overt heart failure, high risk of cardiogenic shock and bradycardia. Prompt reperfusion with percutaneous intervention. Ideal first medical contact to PCI is less than 90 minutes, and statin therapy as soon as possible. Then we have initial stabilization of acute ST elevation MI. So how do we do that? So firstly, supplemental oxygen if SaO2 is less than 90% or dyspnea. Aspirin 325 milligrams. P2 white valve inhibitors, for example, clopidogrel, nitrate, sublingual, beta blockers, unless hypotension, bradycardia, chronic heart failure, and heart block. High dose statin like atorvastatin, 80 milligram. Then anticoagulation. The anticoagulation drug depends on the planned revascularization. Okay, then we have persistent pain, hypertension, or heart failure. Intravenous nitroglycerin not if hypo. Intravenous nitroglycerin not if hypotension. Right ventricular infarct or severe aortic stenosis occurs. Persistent severe pain, intravenous morphine. Unstable sinus bradycardia, intravenous atropine. Pulmonary edema, intravenous furosemide. Not if the patient is hypotensive or hypovolemic. Reperfusion, percutaneous transluminal coronary angioplasty PTCA within 90 minutes is preferred. Thrombolysis if PTCA is not available within 120 minutes. And they are saying here again the same thing, Mona C. Bash. What is the management of unstable angina and NSTEMI? So the management is nitrates, caution with hypotension, for example, right ventricular infarction, beta blockers, cardioselective, for example, metoprolol and atenolol, contraindication in the heart failure and bradycardia, and intravenous for hypertensive patients, antiplatelet therapy aspirin for the P2 white valve receptor blocker, for example, clopidogrel, anticoagulation with UHF that is UFH that is unfractionated heparin, enoxaparin, bivalodin or fondaparinux. The statin therapy, high intensity, for example, atorvastatin and rosuvastatin, and coronary reperfusion, percutaneous coronary intervention within 24 hours. Mona C bash means morphine, oxygen, nitrates, aspirin, clopidogrel, aspirin with clopidogrel, so it is double anti-platelet therapy. Then beta blockers, ACE inhibitors, statins, and heparin. Medications with decreased mortality in MI, ACE inhibitors, angiotensin receptor blockers, beta blockers, mineralocorticoid receptor antagonist, combination of hydralazine and nitrates only in the African Americans. Heart sounds during the MI. Firstly, an abnormal S4 atrial gallop can be heard in most patients during the acute phase of myocardial infarction due to ischemia-induced myocardial dysfunction. Sinus tachycardia. The P waves usually before QRS complex. Ventricular rate of more than 100 beats per minute. P waves are usually upright in the lead 1 to AVF V3 to V6. Maximal heart rate in the sinus tachycardia can be determined beats per minute are 220 minus age. Beats per minute, so basically we do beats per minute is equal to 220 minus age. Okay, so this is what it looks like. PR interval more than 120 milliseconds greater or equal to 3 small boxes. Then sustained monomorphic ventricular tachycardia. QRS complexes are wide and all match each other. Okay, Fusion beats capture of electrical signal through both the atrium and ventricle briefly. A hybrid of a normal and wide QRS complex, P wave precedes the fusion complex. What? Sustained monomorphic ventricular tachycardia looks like this. Like this is the explanation of this ECG. They're saying that there will be fusion beats like this and this. Capture of electrical signal through both the atrium and ventricle briefly. A hybrid of normal and wide QRS complex, P wave precede fusion complex. Monomorphic ventricular tachycardia QRS complexes are wide and all match each other. So the features are wide QRS complex which all match each other. Fusion beats are diagnostic. The risk factors include ventricular systolic dysfunction and coronary heart disease. Management is hemodynamically for hemodynamically unstable patients do the synchronized cardioversion, and for the hemodynamically stable patients we can give IV amiodarone. Approach to wide complex tachycardia. So first look for AV dissociation and fusion or capture beats. If they are present, diagnosis of ventricular tachycardia. If the person is stable, give IV amiodarone. If the person is unstable, like hypotension, altered mental status, or respiratory distress, go with synchronized cardioversion. So then, if AV dissociation and fusion capture beats are not present, then consider supraventricular tachycardia with aberrancy. If the person is stable, so maneuvers to determine the rhythm like cardiac, carotid, Versailles, rate control, and then treat the patient. If the person is unstable, like with hypotension, altered mentation, and respiratory distress, do the synchronized cardioversion. Then the next thing is about the supraventricular tachycardia. So in supraventricular tachycardia, the problem is that mostly narrow QRS complex tachycardia. Usually there are no regular P waves as they are buried within the QRS complexes because the QRS complexes are okay. Like I believe that QRS complexes are happening in such a rapid frequency that the P waves are not evident on the ECG, but retrograde P waves can occur. Then there can be retrograde P waves seen in the beginning or end of a QRS complex when atria and ventricle are not simultaneous. Can appear as spikes in the QRS complexes or as inverted P wave. So here you can see these dark dots like I'm here, I'm here, I'm here. Like this one, this one, this one. These are retrograde P waves, pseudo S waves. These ones are retrograde P waves, pseudo R dash waves. These ones RR intervals are constant, but they are like the heart rate is too much. Okay, then we have this is tachycardia originating above the bundle of his. It includes sinus tachycardia, multifocal atrial tachycardia, atrial flutter, fibrillation, AB nodal reentrant tachycardia, and AB reentrant tachycardia, junctional tachycardia. Management for hemodynamically stable patients, the main step is to determine the type of supraventricular tachycardia with the use of following. We can do either vagal maneuvers or IV adenosine. Okay. Now this ECG strip is for the paroxysmal supraventricular tachycardia. The features include regular narrow complex tachycardia. It includes AV NRT, AV RT, atrial tachycardia, and junctional tachycardia. Management. Vagal maneuvers increase the parasympathetic tone in the heart and result in temporary slowing of the conduction in the AV node and increased AV nodal refractive period. These maneuvers are carotid sinus massage, cold water immersion reflex, Valsalva maneuver, and eyeball pressure. Adenosine can be given. Both of these treatment options can cause transient AV block and slow the ventricular rates. Then for this was supraventricular tachycardia, right? There's a variant of that. No, this was paroxysmal supraventricular tachycardia. Okay. Again, atrioventricular nodal reentrant tachycardia. AVNRT is a type of paroxysmal supraventricular tachycardia. So you can see that this is normal ECG, and this is the point from where the supraventricular tachycardia has started. From here onwards, the heart rate is more than 150 and the rhythm is regular. P waves often not visible, buried in the QRS or T wave, abnormal shape if seen. So it is the most common cause of supraventricular tachycardia, atrioventricular nodal reentrant tachycardia. It results from the reentrant circuit formed by two separate conducting pathways, one fast and other slow, within the AV node. So this is very important. This is the reentrant pathway that is formed inside the AV node itself. If an atypical premature beat occurs at a critical time when the fast pathway is refractory but slow pathway is not, it can initiate the AV nodal reentrant tachycardia that is sustained by a re-entry mechanism. Impulses travel in anterograde direction through slow pathway and return through the fast pathway. Okay. Like they are moving anterograde from the slow pathway and they are returning back from the fast pathway. Presentation is sudden onset and termination, regular rhythm, heart rate of 140 to 250 per minute, narrow QRS complex and absence of P waves. So conduction during the normal sinus rhythm. This is the fast pathway long refractive period and slow pathway short refractive period. And this is the bundle of S. So like this is the slow pathway is blocked and normal conduction to the ventricles. If there is a premature atrial contraction, so the fast pathway was in the refractive period, so the impulse started traveling in a slow pathway, right? And then came back from the fast pathway. Normal impulse already through the circuit, but the conduction up to the fast pathway initiated the re-entry circuit. Retrograde conduction to the atria P wave buried in the QRS complex and re-entry circuit perpetuates. Adverse effects of amiodarone. So major side effects are as follows: the cardiac, pulmonary, endocrine, gastrointestinal, ocular, and dermatologic and neurologic. The cardiac side effects include sinus bradycardia and heart block. There are risk of proarrhythmias, QT prolongation, and risk of torsion de pointes. Pulmonary side effects include chronic interstitial pneumonitis, cough, fever, dyspnea, pulmonary infiltrates are most common. Endocrine causes include hypothyroidism and hyperthyroidism. Gastrointestinal and hepatic causes include elevated transaminases and hepatitis. Ocular, these are not causes, these are gastric side effects. Yeah, so ocular effects include corneal microdeposits and optic neuropathy. Dermatologic manifestations include blue-gray skin discoloration, and the neurologic manifestations include peripheral neuropathy. Pulmonary toxicity, it is correlated with the total cumulative dose and occurs months to years after initiation of the drug therapy. Manifestation, chronic interstitial pneumonitis occurs within months of therapy. Chest X-ray may show presence of localized or diffuse reticular or ground glass opacities which can be migratory. Organizing pneumonia, ARDS, diffuse alveolar hemorrhage, pulmonary nodules, and pulmonary solitary masses. Screening, baseline chest radiograph and pulmonary function tests followed by long-term surveillance. Pulmonary function test may show restrictive pattern with a reduced DLCU. Other screening, periodic thyroid function markers screening, periodic hepatic function marker screening, and any unexpected visual symptom should prompt a thorough ophthalmologic examination as well. Use dependence is a separate topic, but okay, let's read it. So, use dependence means it is shown by class 1 antiarrhythmic drugs and class 4 calcium channel blocker antiarrhythmics. It states that the degree of block is proportional to the rate of nerve stimulation. It is associated with the rate of drug binding and dissociation of the antiarrhythmic drug. The class 1C has lowest binding, it goes like CAB. So class 1C has the slowest binding and dissociation from the sodium channel receptors. Hence, increased cardiac activity like tachycardia, the use dependence quality of 1C drug causes more potent antiarrhythmic activity because drug has less time to dissociate from the sodium channels. The decrease in impulse conduction and widened QRS complex. Drug binding and use dependency is seen most commonly in 1C and least commonly in 1B, so it goes like CAP. Class 4 use dependence leads to increased PR interval due to prolongation of the refractive periods of the AV node. We'll keep this session till here. See you next time. Until then, Allah Hafiz.